We are here today with Ginger Biesbrock and Jacob Turmell of MedAxiom Consulting, both vice presidents, and they've just given us a timely presentation on re-engineering care delivery. Thank you guys so much for that really engaging and provocative presentation. You outlined a lot of issues that are going on in healthcare and the need for re-engineering healthcare delivery. Can you summarize some of those key points for us?
You want to start, Jacob?
Yeah, I think the first thing that I've seen in healthcare delivery today is really making sure that we're keeping the patient at the center of what we're doing. I think that as healthcare has evolved, one of the things that we've gotten away from is remembering that at the middle of everything we do is a patient. And so as we are going about our daily work, it tends to end up being what's best for the physician, what's best for the practice, what's best for the hospital. But we have to remember we're here to serve patients. And I think that's really led to some of the issues that we're seeing around care delivery.
And how do you feel that the patient is not being served today?
I find that we're very reactive in the way we deliver our care. We wait for the need, and then we scramble to meet the need. Mm-hmm. And you know, we're moving into an environment where we're, I guess, incentivized to cut costs. Historically, if you have an acute need, our best place to go is the emergency room. And we really, the emergency room is not the best place to get good cardiovascular care. And so we're really kind of pushing our programs to think about it differently, be more available, and really build in and anticipate those either whether it's new patients that need to be seen urgently or established patients that have urgent needs, changes in symptoms, build into their programs an ability to anticipate and manage those patients in real time. It's more cost effective, it leads to better patient satisfaction. We have the right people providing the care, and it's just kind of a win-win for everybody. I think the reason we've struggled with some of that is a couple-fold. One is we push very hard to drive volumes, and we're always just a little bit understaffed because resources are always an issue, and that's how we end up being very reactive. Pushing it to be much more proactive, there is a risk of I might have a person available to see those patients, but what if I don't have patients? So we try to anticipate a need. So there's a little bit of a risk there, but the benefit of having that availability, being able to take that extra time, in our opinion, far outweighs the benefit.
So
far outweighs the risk.
Is it a matter of trial and error when you get a new program started, that you know that there might be some downtime for some of the providers while you figure out what's the right formula?
I think there is a little bit of that trial and error piece, but I think there are also pockets of best practice that are out there that you can really model your program around. And that's really where I think our presentation comes in and say, here are where organizations are doing a good job with this already. Your program might be a little bit different, your patient needs might be a little bit different, but here's a starting point. So you don't have to start with trial and error, you kind of have a guideline to start with before you start that journey.
You gave a lot of great examples of programs, best practices. What are some of the ones that you would like to share right now? Programs that are doing great jobs in pockets maybe where others could learn from.
Yeah. I think the way we organized the presentation today is we really looked at three main areas. So the first one was access, and it's just opening themselves up to manage patients in real time. Today patients call in, we can get them in today, we can get them in tomorrow. Mm-hmm. The second area that we looked at was related to I guess I would say resource utilization, but really developing out those teams. You may not always have that physician available, but what can we offload from that physician into a team-based environment to create better access for our patients? So we talked about RN triage and effective management for those telephone needs and the follow-up needs. We talked about care teams with the use of APPs and really expanding your provider resource or your provider capacity by 2 or 3 heads are better than 1 to create more availability.
Well, I think the other key thing too is looking at different specialty clinics. So thinking about patients not in just a general sense of a cardiac patient, but what are the special needs around a heart failure patient or an AFib patient, and how can we pull those patients out of the general mix, provide to them the specialty care that they need in a new model using a team-based care model where you really are focusing more on that patient need and having experts really delivering the care that's needed for those diagnoses.
The other thing I would add that we talked about today was we've been to a lot of places that have attempted to do this work, and I've had people ask me that, oh, we've got the staff and we may even have some protocols, but it just doesn't seem to be working for us. And when we go in and kind of dig a little bit deeper to find out what's really getting in the way, I think what we're finding is we don't have a strong commitment by the entire program to utilize that particular process or that particular clinic. Maybe we haven't defined appropriately which patients would best be managed that way, and then committed that those patients, if they meet that criteria, will be seen in those programs. I think we haven't sometimes protected, if we've got an incentive model related to the way our physicians are compensated based on the number of things that they do, and we set up a system where we need them available to manage some of these acute or urgent needs, but they're not always that busy. I kind of gave the example of you put somebody in a same-day visit or an urgent new patient role, and the first day they don't have a full day. When they're in that role again, they're going to go behind you and schedule patients in those slots because they know they have patients that need to be seen, and then they feel it's in their best interest to be utilized to see patients. So there's a lot of leadership, administrative, and alignment work that needs to be done on the back end, or these programs don't work.
Right.
And I think one of the things that we're seeing too is in the way that payers are paying. So it's no longer around how many widgets are you producing, in that fee-for-service model. As we move to value, I think that our payers are really saying these are the types of programs that we need to have in place, where we're looking at it from a patient-centric view and making sure that we're managing care in a very different way. As we start looking at QPP and start looking at BPCI Advanced, those models are actually saying we're going to reward you for this type of work, which is a big shift as well.
What would you say would be recommended first step? This is a big, complicated issue and transition. If people are saying we know we need to do this, where do we begin?
I believe it starts with the initial vision and then commitment, and putting some resources behind it. So it starts as it's a leadership decision, physician leadership, administrative leadership.
Did you use the phrase deliberate decision?
Yes, deliberate. It's we are committed to. So I hear a lot of people ask the question, if we get what should be the normal time frame to get a new patient in? And we've got people, we have a lot of examples come through from our members. Some say 5 days, some say 2 days, some say we say 2 days, but the average is really probably 10 days. So we think a lot about it, and we know what we would like, but at some point you just have to commit. And by committing, then build a process, monitor the process, and when the process starts to fall out, then you go back and you revisit and you recreate, you re-engineer, but what is the goal, and you work towards the goal. But I think it starts with developing. We are going to commit to whatever that particular piece of delivery is. We are going to commit to that care objective.
I think Ginger did a great job explaining the whole process improvement process, and part of it is really that committing up front, but having a good plan in place is key to success. Call these programs that are already doing this work and ask them, what were the barriers, what were the struggles that you had? Make those connections. The other thing that I think is key is bring some patients in. Let them be part of that process improvement. Hear the voice of the patient to really get to understand from their viewpoint what is acceptable or not. I mean, if you're looking at nurses calling you back, I may, as a provider, think, if I call you back in 2 or 3 days, that's good.
Right.
A patient may say, no, 2 to 3 hours is my expectation.
Because you gave the example of an AFib patient where the provider might know that they're not in danger, but to
Right.
that patient,
They're
scared.
Absolutely.
Yeah.
And so I think bringing that patient in and hearing the voice of your patients is huge with doing any type of process improvement work. So I think that commitment is huge, but also talking to your patients and understanding what their needs are makes a big
And
difference.
that's something that all of CV Healthcare could benefit from, is bringing that patient in
Absolutely.
as they're trying to come up with these new processes to improve and transform.
Absolutely.
Thank you guys so much. Appreciate your time and your insights.
Absolutely. Thank you.
you.